Hello everyone, welcome to the next edition of Spotters and Shooters, that is the 8th edition, and here we will focus on how to make most out of the theory examination, how to perform short notes in exam. Solutions to the previous homework, that is episode 7, question 1 was a drug that inhibits thrombin-mediated platelet activation by targeting protease-activated receptor, which is the major thrombin receptor on the platelets. The answer is vorapaxar. Is a newer drug. Question 2 is mention a drug that is used as both in vivo and in vitro anticoagulant. The answer is heparin. We already know that there are heparinized vials which contain heparin magnesium. Question 3. Name a diuretic that has potent uric action. Benzbromeron. Question 4. How does dotinurad act in chronic gout? Dotinurad is a newer drug, a derivative of benzbromeron, and potent inhibitor of the transport of urate in proximal convoluted tubules. And by this mechanism, it inhibits renal tubular reabsorption and thereby enhances uric acid excretion. However, continued use of dotinurad may cause renal calculi formation. Which other drug causes a renal stone? We must remember topiramate, which is anti-epileptic and used in migraine prophylaxis, may also cause. Question 5. What do we mean by capacity limited and flow limited elimination? This can sometimes be a very brief note also. Flow dependent elimination means elimination depends on hepatic blood flow, which is normally 800 to 1500 ml per minute, and most of the drug is eliminated during its first passage in the livers because liver has a great capacity to metabolize it. So it is not the capacity, it is the blood flow that determines the eventual elimination. Many drugs exhibit this phenomena and they may be clinically relevant as well. Beta blockers, antidepressants, opioids, verapamil, isoniazid, and warfarin. They all may show this type of elimination. The second one is capacity limited elimination, where clearance varies with concentration of the drug achieved. Because there is a limited capacity, they exhibit saturation kinetics, phenytoin, ethanol, and aspirin. Because they exhibit and follow the zero order kinetics, the capacity to metabolize is limited, and if the dose is increased, there will be more toxicity because clearance will change. Now question 6 is mentioned an osmotic diuretic that causes glucouresis, natriuresis, but little kiliuresis. The gliflozins, particularly dapagliflozin and empagliflozin, which are used as anti-diabetic drugs, they are basically glucose excreting drugs. They also cause volume loss and natriuresis. But kaliuresis little because most of the sodium and most of the potassium which is lost in proximal tubule is exchanged and conserved in the distal part of the tubule. Question 7. Mention a drug that increases free water clearance, which is known as aquaretic. And what could be possible use of such drug? Vasopressin V2 antagonist tolvaptan. Another is mozavaptan, and they are mainly used in the treatment of syndrome of inappropriate ADS secretion in which there is water retention and intoxication, congestive failure with water overload, autosomal polycystic kidney disease, and is also used to reduce volume overload and cirrhosis with ascites. Question 8. What are the uses of vasopressin analog desmopressin? Desmopressin is a longer-acting form of vasopressin which is used in the treatment of central diabetes insipidus, but it is not used in the treatment of nephrogenic diabetes insipidus. This agent has also been found useful in hemophilia A and von Willebrand disease type 1, and here it stimulates the secretion of VW factor and factor VIII from the storage sites in the vascular endothelia by V2 receptor stimulation. Desmopressin is used because it is a very high V2 to V1 selectivity. So vascular effects are minimal. It is also effective in primary nocturnal neurosis where it is used as nasal spray. Currently it is said that tablet is better than nasal spray. And to relieve lumbar puncture headache, it has been used. Desmopressin is not effective in hemophilia B usually, and it is not used in the treatment of bleeding esophageal viruses because it has V2 effects rather than V1 effect. Question 9 is a diuretic that is used in lithium-induced nephrogenic diabetes. Here we use amiloride, which is a potassium-sparing diuretic, and it inhibits the lithium uptake by sodium channels in collecting duct system. Therefore, lithium excretion increases. And the question 10 is an antibiotic that antagonizes ADH. D-methylchlorotetracycline is an older tetracycline that may induce nephrogenic diabetes and is useful in water intoxication. We begin with the problem now. A short note on aromatase inhibitors. We will outline our short note. What is it? How does it act? What are the potential uses? What are the pharmacological characteristics, values, limitations, and ADRs? Now, aromatase inhibitors are increasingly becoming important drugs, and they have selective inhibition of formation of estrogen, decreasing estrogen levels in by acting on peripheral tissues and tumor tissues, and where they inhibit aromatase. They also inhibit aromatase in adrenal gland, liver, and breast carcinomatous cells. There are two types. Type 1 are steroidal, which are irreversible. We can call them suicidal inhibitors. The type 2 are non-steroidal, which are reversible, but currently type 2 are more commonly used. Now type 1 and type 2 are again subdivided as first, second, third generation. Currently formistine and third generation exemestane belong to steroidal irreversible drugs, and currently anastrozole, letrozole and vorozole are the third generation type 2 which are commonly used. Ketoconazole has non-selective action. It does not inhibit the ovarian aromatase, but it reduces placental activity. So it is. Now question is, how do they act? Aromatase enzyme is a cytochrome enzyme that converts androstenedione to estrone on one hand, so that there is subsequently less formation of estradiol. One. Second is, it also in peripheral tissues, it converts testosterone into estradiol by aromatase enzyme is inhibited by inhibitors. So estradiol formation is markedly reduced. It must be understood that under the influence of LH, theca cells secrete androstenedione and DHEA. Now DHEA through enzymatic conversions may also ultimately form estriol, which is biologically active form also, through aromatase enzyme. So some estriol formation is also inhibited by this mechanism. Aromatase enzyme is induced by FSH. When FSH is secreted, there is greater activity of aromatase enzyme. So what does we mean is, when aromatase inhibitors are used, there may be more secretion of FSH. Now comparative pharmacology of three drugs which are currently used, anastrozole, letrozole and exemestane, which is a steroidal one. Reversible inhibition is shown by anastrozole and letrozole, and suicidal inhibition by exemestane. Which other drug shows suicidal inhibition of enzyme? The answer is clavulanic acid, which is a beta-lactamase inhibitor. It is a suicidal inhibitor. Now, absorption of anastrozole is almost 50%. Letrozole is also 60%. Exemestane is 40%. I'll repeat, absorption is rapid, letrozole 100% and exemestane 40%, but absorption increases with food. Anastrozole absorption is reduced. Metabolism is through cytochrome 3A4 enzymes. Eventually, glucuronidation occurs with anastrozole. Letrozole is metabolized by two enzymes, 2A6 and 3A4, and multiple enzymes metabolize excimetins almost completely into some active, some inactive forms. One of the active is 17-hydroxy metabolite of excimetins that has weak androgenic activity. Excretion is mainly 90% fecal anastrozole, mainly renal letrozole, and renal and fecal of exemestane. Adverse reactions are more or less common among these three drugs, and there are symptomatic arthralgia, vaginal dryness, sexual dysfunction, and maybe fetotoxic. Exemestane has particularly been found to be fetotoxic. Anastrozole and letrozole dose to dose are more potent. So what are their potential therapeutic uses? Aromatase inhibitors are the first and the foremost used in carcinoma breast in various stages. Second is gonadotropin releasing hormone independent precocious puberty, and the third is follicular development and ovulation induction in the place of clomiphene in the infertility caused by PCOD, and is also used to induce ovulation and in vitro fertilization. For this purpose, letrozole is used for a shorter period, typically starting from third day of the menstrual cycle, and this induces follicle development by inhibiting estrogen biosynthesis, decreasing estrogen level, and thereby increasing FSH levels, and this develops follicles. Advantages of use of letrozole over clomiphene is more effective than clomiphene, less hot flashes, mood changes, and less multiple pregnancies. So that is a very important one. But the limitation is risk of osteoporosis if it is used for longer time, whereas clomiphene may not have. So far as use in carcinoma of breast is concerned, aromatase inhibitors have become almost first-line treatment for carcinoma breast or as second-line treatment after tamoxifen. They are highly effective and superior to tamoxifen as adjuvants for post-menopausal women, and they are indicated either following tamoxifen for 2 to 5 years, extended up to 10 years, or as initial agents also. A recommended standard adjuvant treatment of ER positive is AI, letrozole, with other or exemestane, anastrozole, with other agents in hormone positive metastatic carcinoma breast is another indication, and has also been recommended as chemo prevention of carcinoma breast in high risk females, and it is given for chemo prevention for up to 5 years. In premenopausal women less than 35 years alone they are not given, whereas in early carcinoma breast, anastrozole is combined with ovarian suppression by using GnRH analog leuprolide, and this combination is more effective than tamoxifen. So it is used in combination but not in alone. Exemestane with rapamycin is also indicated in advanced carcinoma breast progressing after use of aromatase inhibitors, that is non-steroidal inhibitor. After letrozole, one may give exemestane for further prolongation. It is also used in male breast carcinoma with leuprolide. Now, compared to tamoxifen, which is the gold standard for carcinoma breast, there are many advantages. One is no increase in the risk of uterine cancer because endometrial proliferation does not occur. There is no risk of or less risk of venous thromboembolism, greater delay of the breast cancer recurrence than tamoxifen. That is important, and effective in tamoxifen failure. There are demerits also because they markedly reduce circulating and local levels of estrogen. They produce hot flashes, although they may be less, but that is there. They lack the beneficial effect of tamoxifen to maintain bone density, so they may cause osteoporosis and increase the risk of fractures. They must be given with bisphosphonates to avoid this problem. The effects on plasma lipid remain to be established. At present, it is not known they are good or bad. They are not recommended for pre-menopausal calcium-based alone, but tamoxifen is indicated, whether it is pre or post-menopausal, and no benefit effects of the lipids have been shown till date. Now, this is all about the short note you can perform. Now, homework for self-directed learning is: what are the sources of estrogen at various stages of development and life? Question 2. How do estrogens increase clotting and thromboembolism? This is a clinically relevant question. Question 3. Explain why letrozole alone is not recommended for the treatment of carcinoma breast in premenopausal women. And question 4. An intravenous generalized agent that inhibits glucocorticoid biogenesis by inhibiting 11 hydroxylase enzyme and occasionally used for rapid control symptoms and Cushing crisis. What is that intravenous agent? General anesthetic agent. And question 5 is a drug that inhibits adrenal androgen by. Another question is a drug in the form of MCQ, a drug that stimulates new bone formation of osteoporosis. 4 options are there. You have to identify the correct option. Question 7 is a drug of choice for carcinoma breast in premenopausal woman. You can easily find out. And the question 8 is write a short note on selective estrogen receptor modulators. You try to attempt on the same theme which I have discussed, and if you find easy through books, it will be helpful to you. And the next episode of the spotters and boosters to find the solution.